Hi, I'm Craig Lammert, the Executive Director of the Autoimmune Hepatitis Association. I'm also a hepatologist at Indiana University. We know the popularity and use of living organ donation as a means to treat chronic liver disease has increased dramatically in recent years as an alternative to the traditional deceased organ donation because of growing need for livers for transplantation and limited availability of organs. Indiana University has just relaunched its Living Donor program as a way to help with possible shortcomings of available organs for patients. I was lucky enough to sit down with my colleague, Dr. Marco Lacerda, the medical director of the Indiana University Liver Transplant Program, to find out more about Living Donor and when it may be an option for a patient. Hey, Dr. Lacerda, thanks so much for joining us today.
Hey, my pleasure. Thanks for having me.
Well, it's our pleasure, and we know IU, Indiana University, is making the news recently as we have recently opened and started our Living Donor Transplant Program, and we're really happy to be able to talk to you about this. Maybe we could start with some basic questions. What exactly is living donor transplantation?
So, living donor liver transplantation is a situation, it's a little bit different than, for instance, kidney transplantation, in which we talk and we hear way more about living donation, because since you have two kidneys, a living healthy person offers to donate one kidney that is almost a spare one and will make no difference if that is donated. And that's what we use to see the most. In liver transplantation, it's a bit different because since we have one liver only, we can only consider liver donation if somebody is able and willing to donate a portion of a liver. This is something that was not considered until the 80s because liver resection was a very difficult surgery. And then it was started initially in pediatrics, in which a smaller area of the liver, which is the left side of the liver, being a smaller, and I won't say easy operation, but less of a burden of operation, was started. And through the 90s, it grew substantially, mostly in the East, in the Asian countries. But by the late 90s, there were some new techniques that were developed and made possible for adults to donate to adults, donating portion of the right lobe of the liver, which is a larger part of the liver, and in a safer manner. And since then, it's been done routinely in the nation. Specifically about, and the purpose of this is to try to shorten waiting time for people that are really suffering the transplant list, not being able to be called in for a transplant for a deceased donor. That's pretty much the major reason in an attempt to expand the donor pool.
Right, and maybe I could stop you there for a moment and ask you, generally, how do patients do after living donor transplant as opposed to the other alternative, deceased donor transplant?
So the results are supposed to be the same. There are some factors that can benefit the living donation liver transplantation recipient compared to the deceased donor that I can explain in a bit more detail. But as a rule, they should do as well as anybody that has received a complete entire liver.
That's quite reassuring. And I think the other big question a lot of our patients ask is, I feel sick with this disease. I have a lot of extrahepatic symptoms or symptoms outside the liver. Do I qualify for a living donor? How sick do I have to physically be for a living donor transplant?
So the criteria for one to be considered for a living donor liver transplantation is not different than the criteria that is considered for people that are to be considered for a deceased donor. They are the same. We are not to consider living donation for somebody that doesn't quite meet criteria, for instance, to expedite a transplant before it is time. So normally, all the usual unfortunate complications that can come with chronic liver disease, including difficult to treat ascites, pleural effusion that has to be drained repeatedly, recurring encephalopathy, or a rising MELD score purely, those are indications, as they are for people that are considered for deceased donor liver transplantation as well. So the indications do not differ. The major impact that living donor liver transplantation can cause is based on people that have lower MELD scores, and therefore their prospective waiting time is longer, sometimes too long for them, and especially mostly in areas of the country where the waiting times are much longer.
Right. So I think, again, reassuring news for patients. But as they talk to their family and they're considering this adoption, how would you guide a patient and their family to start to explore this possibility, particularly what resources are in their local community or transplant centers nearby?
So this is something that can be discussed, I would say, initially with their primary hepatologist. If somebody is already being considered for liver transplantation, we expect their liver doctors to be well versed in the matter of living donor liver transplantation, and that can start the conversation. Uh, of course, not every center does it, but if not available locally, there are many centers across the nation that can receive those patients. And they are well-trained, experienced centers with good results. In terms of how to get a donor, that's a more sensitive issue because it's something that we have to be very careful on how to approach. Normally, and this is something that all of us that are involved with people with end-stage liver disease, we are used to see is that during their first or second visit with us in clinic, the family already approaches asking about the possibility of living donation. And when the family, not specifically the patient, bring this about, this really opens a door for discussion. When there is somebody that already has this perspective and understanding, and there are people that around him or her are willing to be donors, we have a team that can help sort donors and help educate donors. We have a living donor champion, both in the kidney and the liver transplant programs that can help in this regard. So there are way more donors out there than actually we think about, because it's something that, being unusual, we don't talk so much about. But when the program is ongoing like this, we begin to see that there are way more volunteers and good Samaritans out there that want to help.
Right, and that's great. And you've painted many advantages to living donor transplant. Is there any negatives or limitations to living donor?
Let me start with the positives, because I think that's important to know. What is positive is that the first, we expect somebody not to wait so long in the waiting list. And of course, somebody that needs a liver transplant is not somebody that's getting any healthier. As a rule, unfortunately, gradually they get sicker. So the longer the wait, it's likely that they're going to be sicker at the time of transplant, increasing their risk and delaying their recovery. So if we are able to have a more timely surgery that can be pre-planned, not done urgently, possibly that will give a chance of the patient not to deteriorate so much before a deceased donor is available for them. So this is one thing that is very important in terms of the positive. The fact that we have time to prepare and analyze the donors normally say it can be even safer because we have time to get to know the donor better, be reassured of how healthy they are, and if there are any questions at all, if physical or emotional, they can be dealt with before. So that truly increases the safety of living donation. The last point is that since the surgery is pre-planned and it's done in tandem, both the donor and the recipient, the donated liver doesn't suffer as much outside the body like a liver that is donated, for instance, 500 miles away. So that could bring better results in the future. There is always a question if it is enough liver for a patient to receive, or if there is enough liver left to the donor. And this is calculated very, very carefully before the procedure itself. One thing that is important to know is that if a donor donates, for instance, 40 to 60%, in average 50 to 60% of their donors or their donor liver to the recipient, and of course the recipient will receive about half of that liver. In about 4 weeks, the liver volume for both of them, for the donor and for the recipient, will be about 95, 98% of the expected volume. So the healthy liver will grow very rapidly. So all of that is very positive. What could be negative? The surgery for a donor is not completely devoid of risk. So that's the first consideration in terms of something that is negative. Exceptional care is taken for the donor to be safe, of course. We surround the donor of every form of care that we can think of to make sure that this is safe. But again, like any other procedure, there is always a risk involved. There is a risk of mortality for the donor, which is exceptionally low, something likely of the order of 0.1%, which is almost negligible for a surgery. But again, we have always to remember that there is somebody that we have to be very careful with. For the donor, there is always the concern if there is any complication from the surgery, if they can take a few weeks more to recover than expected. But as a rule, the donor will be safe and will recover rapidly because it's a healthy person.
Right.
For the recipient, virtually no downsides to this. The surgery is about the same as it is for the deceased donor. It can involve a little bit more work for the surgeons to rearrange the blood vessels and the bile ducts, but as a rule for the recipient, the risks and the recovery tend to be similar.
Yeah, so that's great news. Speaking of donors, and maybe we should just, in a nutshell, what should a possible donor expect, saying that they go through all the channels through their own local center and they are a possible match or a candidate?
So, as a rule, the donor should be the same blood type as the recipient. There are situations in which we could consider across blood types. As of now, we prefer not to do so. There are centers that would do. Being the same blood type, we expect the donor to be somebody that is an adult, to make conscious and responsible decisions, and healthy otherwise. Any significant health issues will be an impairment because we don't want to take any chances with the donor. Of course, the donated organ would be healthy, but if the donor has already some health conditions, we don't want to add any stress to their bodies. So a healthy adult that is of sane mind in making that decision could be considered. Some initial consideration is triaged via questionnaire, which can be done online in our website. And then once that is cleared, we start some tests with some general testing, including blood tests, some imaging of the liver, and a visit with our psychologist as well, which is very important to understand reasons for donation, emotional safety of the donor for this procedure. Once all of those are cleared, we bring this for discussion in our liver transplant committee for approval, both for the donor and the recipient to be a match.
Fantastic. So I think that really gives a good snapshot for our patients and members about perceiving this. My next question and last question is, IU is now doing living donor transplant, as we've talked about. Any anecdotal experiences that you've perceived moving through this process, and even with the first few cases that we've done?
Yeah. So I think the right way to say is that IU is restarting its program. IU has done very few living donor liver transplantations in the distant past, in the early 90s. But after that, we didn't do any, actually, because we didn't need it. Indiana was known across the nation to have a very short waiting time, and for that reason, we never needed it. So for the past few years, we noticed that our waiting times was increasing, and therefore that need might be present in the future. And about a year ago only, there was a decision in terms of changing the liver allocation in the country that has benefited some other centers because livers are being distributed in a different manner, but it has really impacted our state significantly. And that's the reason we restarted the program. So we have well-trained surgeons, very experienced surgeons that we have started. And we have been doing so far quite well with our beginning. There are very interesting stories, but I couldn't, and one thing that I should mention here is that among these stories, and this is one thing that may be surprising for most of us, is there are many altruistic donors out there, people that are unrelated to a diseased person, and they simply want to help. And we have received several offers, and we have a few donors in evaluation that didn't have a particular person in mind that they wanted to donate to. They just wanted to help somebody, really as a good Samaritan. So one of our transplants was done in a situation like that. A young lady that was exceptionally healthy, just wanted to help somebody, and she donated. Surgery went well, she recovered well. The recipient, that was a young gentleman, recovered quite well as well. But the interesting part is that, again, I have no direct interaction when my patient is involved with the donor and vice versa. And they have no information of who they are donating to, unless, of course, is directed. And when the recipient's wife was waiting for him in the waiting area, in the surgical area, the donor's husband was waiting there, and they knew each other.
Wow.
That was something that was exceptionally emotional. And in recovery, everybody was so happy. So there are some stories that are really amazing, and they really makes us quite humble to see how good some people can be. It's just unbelievable.
Oh, what a great story. And I want to end there and thank you for all your time and the clarity in helping us demystify this process of living donor transplant. But thank you again for your time, Dr.
It's my pleasure. At any time.